we figure that out.
Well, hi, everyone, and thank you for having us at the AI Summit this year. We're very excited to be here to talk to you about cultivating leadership competency and the virtual reality that we're working on in terms of developing DEI, conflict resolution, and executive or leadership presence scenarios. I'm Dr. Barb Medvik here at the School of Nursing. I'm joined by my collaborators, Dr. Suzanne Knight and Tarnisha McLaughlin-Grayson, and I'll let them introduce themselves as they come into the presentation. So we're excited to share with you our learnings from cultivating leadership competency and the work that we've done so far. We also want to thank the Academic Innovation Center for the startup grant that helped us get this work started in the last year, and we're looking forward to continuing our activity. The purpose of this project was really to develop simulations in virtual reality that will provide leaders with an opportunity to learn about timely and critical topics. The chance to practice how they would address these issues is a critical part of the virtual reality experience, and virtual reality gives them a safe setting in which they can not only receive feedback, practice within scenarios, but also achieve a debrief. So virtual reality fits for allowing leaders to develop these soft skills, if you will, conflict resolution, executive presence, DEI skills, in their own comfort zone, but still get appropriate feedback and develop really a skill set of competency in a safe setting.
Hi, my name is Tanisha McLaughlin-Grayson, Org Development Training Specialist Lead, and I will be reviewing the DEI simulation goals for this experience. The issues of bias and racism in the institution's commitment to diversity, equity, and inclusion require that leaders are knowledgeable and are competent to effectively address situations that arise in a work setting. This scenario is based on several actual incidents in the health system, and extended reality places individuals into real-world situations and scenarios where they can gain and apply knowledge and work through paths that will build effective experience and knowledge using critical decision-making and simulated pathways. Branching scenarios simulate realistic responses to decisions, actions, and interactions. The learner can try different approaches to determine the most effective path and experience the impact of their choices, actions much faster and more effectively than through on-the-job experimentation or role play. We took time at the very beginning to ensure that the learner's specific goals aligned with the experiences that the participants would walk through in this individual simulation. We wanted to provide a safe experience for participants to practice their skills, provide resources that they could refer back to, and allow time for them to reflect on their intended outcomes. So we utilized Uptail for this immersive experience. And as a part of Uptail, you have the opportunity to immerse yourself in the environment through 360 videos. And so the participants actually have the opportunity to actually be in this experience and look around them to see what the room looks like, view the participants' facial expressions and the interactions that they have. Another thing that Uptail provides is it actually records the clicks that people make throughout the simulation. It records where they branch off to, so we can take that feedback from their experience and further or continue the discussion inside the debrief to allow for us to, again, continue that conversation to meet the needs of the learners.
Hi, I'm Suzanne Knight from Nursing Professional Development and Education, and I'm going to talk about our experience developing the simulation. We started with the storyboard process with scene and character development. Our first storyboard was very high level, just laying out the flow of the scenes and which characters would be involved. Our next storyboard was very detailed as we got into what each scene would entail, the script, and the resources. As we began working on the script, we collaborated with content experts and stakeholders to ensure that it was realistic and aligned with our organizational values and education that was already occurring around diversity, equity, inclusion, and anti-racism. Medvec recruited actors for us from her master's leadership students. We gave them the script, but also asked them to ad lib so that it was very realistic. They did an excellent job. We were ready to film. We reserved the clinical simulation center for morning, brought in our actors, and set up the scenes. With the 360 video, we had to be very conscious of what was fully around the camera because it shows every part of that scene. We wanted it to be a realistic clinical setting, and the clinical simulation center was able to provide that. When we did our editing and created the sim and upscale, it required us to follow our storyboard very closely so that we ensured that the simulation flowed and that we accomplished the objectives in the learning experience that we wanted. Once we were done with our simulation, which took several months, we were ready to test it. And again, called on our content experts and stakeholders to give us feedback. Once we had tested it with several people, we went back and did just a little bit more fine editing. We've been talking about how we'll embed it in the curriculum, both at the health system and the School of Nursing. For instance, at the health system, we're going to pilot it with our nurse leader fellows. And at the School of Nursing, Barb Medvec is going to be using it with her master's students. And we've been talking about the best way to evaluate the simulation and the learner experience. So some lessons learned and tips that we'd like to share. It's really important to be very detailed in your storyboard and script so that when you go to film, you capture everything you need during that initial filming process. It's important to test out the filming equipment and output before filming with your actors to make sure everything is working as expected. It's very important to allow for a learning curve and time with the new software. When we first started, we have a very aggressive timeline and quickly found out that it takes a long time and is a very detailed process. So now we have a more realistic timeline for our rollout. And have testers try to break the simulation. Have them go and click through the experience to make sure that all the connections are there and to make sure that it is an easy and meaningful experience for your learners. So this has been a great learning experience for us. We've been getting great feedback from our testers, and we really appreciate this opportunity to delve into virtual reality and how we can develop our leadership competencies through virtual reality. Thank you.
So that was the Cultivating Leadership group working in Uptail, as they said. Now we'll get back to Deb and Melissa. Hopefully we have the PowerPoint issues worked out a little bit better with that extra time.
Okay. So I'm going to share, and I think I just want to share the window.
Correct.
All right, let's try this. Is that working?
Yes, it is.
Perfect.
Yay.
Okay. Deb, you're up.
All right. So we wanted to definitely say thank you to Jeremy Nelson and the Academic Innovation team for inviting us to speak today. And we're really excited to share a project with you. I'm actually in the ICU as we speak and on a guest Wi-Fi, so hopefully this goes okay. But as working in the ICU, we do a lot of procedures. So we do central lines, arterial lines, intubations, and whatnot. And often when I'm teaching a student or a new provider on how to do a procedure, I'd love to review the critical components of anatomy with the patient or with the learner before we start the procedure. And so this is really possible through extended reality. As you know, mixed reality blends the user's world with digital content in such a way that the environments can interact with each other. And so virtual objects behave as if they're in the real world. MR is becoming increasingly more accessible, as we've seen based on this summit at academic institutions, and we're continuing to develop more software and innovation that's occurring. So healthcare continues to adapt and evolve, and we're trying to keep up with that quick pace. And a majority of the learners right now are in an experiential situation where the students are basically using various in-person healthcare simulation technologies. So at our CLC, or Clinical Learning Center, it's basically mannequins, standardized patients, and task trainers. And then as a result of COVID, we decided we wanted to transition as much learning as we could into the mixed reality component and make it appropriate. So I'm going to show you a video of this is our students actually in the lab performing peripheral light and lumbar punctures. And you can see that they've got holographic images. That's okay.
Wait, sorry, I'm sorry.
You can go ahead and play it. You should see some of our holographic images will start to come up. So here's a peripheral IV insertion that we're having the students work with. This is typically undergrad. And then we're also working on a lumbar puncture component here also. This is a student, a graduate student doing lumbar puncture. And what we decided to do was use Microsoft Dynamics 365 guides, and that was really an excellent end user platform. So we didn't have to be coding or designing the actual platform that we're building on. And initially, it was used in the automotive industry. Microsoft 365 guides was for doing assembly line, training people on the assembly line. So we ended up working with the Microsoft designers and the developers over the last 2 years and created 3D images and a medical toolkit in the healthcare sector. So MR has been identified to date as an effective technology for experiential learning. Likewise, mixed reality has positive influences on students' educational experiences, such as increased confidence, interest, motivation, and overall satisfaction. We found that students really like to use the technology as long as they were able to play with it a little bit ahead of time, get comfortable. We've learned that having them do like 3D graffiti or some different things where they're playing with it, and then they start to do the learning component. So we ended up developing these 12 different procedures that are used in our Clinical Learning Center. We have an XR lab within the Clinical Learning Center that students can practice their skills. And ideally, we want students who are having challenges in a particular area to come in and when they're ready to learn, to practice their skills. And then we also have talked about after a clinical day, if they had a challenging procedure that didn't go as well as expected, can they come into the XR lab that night or the next day and actually relearn the skill and make sure that they're doing it correctly? So last summer in the procedures course for the nurse practitioner students, which Dr. Blush and I teach at the School of Nursing, we enrolled 24 graduate nursing students. And basically in our study, they each did a lumbar puncture. And it was after they had done their traditional training. So they had gotten the didactic portion. They had met with faculty and watched faculty actually do the procedure. And then they would come into the XR lab and put on the HoloLens headset. We had a technology, a sim tech, basically there helping them get set up, get in the right place, and then start the procedure. So if they had any questions. And then they each learned their lumbar puncture by doing the mixed reality and the 365 guides is what they ended up doing. And we wanted to really understand, was this usable? Was it acceptable for the students? Did they appreciate this learning methodology? And then also, what was their engagement? Did they feel more engaged or less engaged based on traditional training? So we tested them all and then had them do competency testing. On the system usability scale, or the SUS, they rated it at a 76. So if you know the SUS, you have to be 65 or higher to show that it's actually a usable methodology. And then on our acceptability scale, we were 4.5 out of 5. So we were very happy with that. They thought this was an acceptable approach. And then on our engagement scale was on a 0 to 10, we were 8.29. So, and the students gave us a lot of qualitative feedback as well. They loved it. They wish it would have come up earlier in their program. So we're kind of working on trying to figure out where we can put it into the curriculum earlier. But each of the students were able to pass their competency testing. So they were tested out by faculty after this. And we reduced our faculty time for the procedures course faculty by about 75% by doing this process. And so I'm going to have Dr. Batish kind of talk about our next steps and what we've learned. Unless we lost, okay, there we go.
We do have this video that you could walk through as well, Deb.
Oh, sure. So this is actually one of the students in the headset last summer doing their lumbar puncture. And as you can see, we can put pictures in there, we can put videos, we give them instructions. And here you'll see there's a hologram right on the lumbar spine where they're trying to figure out where their landmarks are, where they're going to be anesthetizing. And then the arrows actually point to what it is, what instrument they need to be picking up. And then we can create targets on the actual task trainer. So this shows the students where they're supposed to be anesthetizing and eventually then where they can poke. So it's supposed to walk them through the procedure.
All right, thanks, Deb. I am now going to share with you some of the things that we learned while working with mixed reality on our project, including some of the challenges that we encountered and future directions. And as with any new technology, technical challenges are expected. And one that we experienced was related to the alignment of the 3D holograms on the task trainers that we were using. We discovered during testing that the holograms used in the guides did not stay accurately aligned between each user, which meant we had to put the headset on and manually align the holograms between each student. And we had 3 students going at a time with 3 HoloLenses being used. So this did become a bit troublesome in terms of the extra time that it took for us to do this, which we hadn't accommodated for in the back-to-back scheduling of each session and the need for additional IT support. But in all, it was a necessary step for us to complete so that we maintained reliability in the user's learning experience. And in order to improve this moving forward, we will provide more pre-learning activities to teach the user proper wear and adjustment of the headset. So for this round of beta testing, we had students watch 2 Microsoft videos, which provided a brief intro to the headset. But in subsequent studies, we'll provide a more comprehensive intro to the device by using videos, tutorials, along with some gaming activities to get the learners more comfortable with the technology prior to using it for training. We want the user to be more comfortable with the steps for signing into the device, opening up the necessary guide, using use of eye movements and hand gestures such as pinching, which will all help the user align the hologram prior to starting the skill, which that will in the end decrease the need for external assistance from faculty or IT, with the end goal being, of course, ease of use and a trouble-free learning experience. As we saw from the first video, we tested a 365 guide that we designed to teach peripheral intravenous catheter insertion with a group of 25 undergrad nursing students at the senior level. And surprisingly, we found that the efficacy scores were overall lower than those of the grad students that we tested. In general, the grad students adapted to the new learning modality more easily and felt more likely to adopt it as a learning technique. And one explanation that we had for this finding is that the graduate students are already registered nurses and they've been out in the workforce and they bring with them some experience in performing nursing skills in the clinical setting with real patients. And as more expert learners, they have automated a lot of the movements and the patterns needed to carry out nursing skills, which allowed them to embrace the actual learning experience itself, where the more novice student had to focus on psychomotor skills and just getting the tactile movement right, in addition to working with unfamiliar medical supplies and equipment that they haven't used before, which could all impact their experience. So this needs further exploration. We have found that there is a learning curve in the adoption of mixed reality in nursing education, and that early exposure may be beneficial in acclimating the learners to this mode. So having identified this, we will in the fall be planning to test the use of some 365 guides that we developed to teach basic nursing skills such as nasogastric tube insertion and sterile urinary catheterization. And we'll introduce that to second-year nursing students who are just beginning their career and learning their clinical skills. And hopefully that will support adoption and become more of a normal part of their clinical education and hands-on experience. So since hands-on skills training in this way is new, it's a pretty pivotal time in moving this forward and expanding its use in healthcare training and beyond. And so looking to the future, we are exploring ways to create a platform so that we can collaborate and share all of the different 365 guides that we've developed. And our vision is to create a library for global use, and we can share our training guides and increase the usability globally and on a larger scale. So what does our future look like, and what are some of the things that we will be focusing on to move this work forward? We envision that the use of mixed reality will continue to grow and evolve and will become an extension of the high and mid fidelity sims that we currently do in our undergrad and grad programs, and certainly become a technology that will complement our distance learning and digital education programs. There are areas of measurement that we think are important as we move forward, assessing inclusiveness of mixed reality and collecting information about the learner's lived experience, so we can explore how it engages learners and its ability to support different learning styles. As Deb mentioned, we will continue to do competency testing against expected standards with standardized grading rubrics. And we will continue to assess competencies with an intervention group, learning through the 365 guides and then the traditional instructor-led methods. The exciting thing is that the use of 365 guides is scalable and can be used for learning and practicing clinical skills at different levels of proficiency. So extending the use to, for example, practicing registered nurses would allow nurses to both learn new skills. They'd be able to refresh their competency for maybe skills that they haven't performed in a while, and even in orientations, in annual competency testing. So all of these things could improve quality of patient care and health outcomes. And similarly, it can be used to train medical students and medical residents in advanced skills and procedures. So we're excited about opportunities for collaboration and global application. We are collaborating with Health Education England and Pan American Health Organization, and we're looking forward to more opportunities to collaborate with others. So we're pretty optimistic that mixed reality is going to be a key element in clinical training and become a new norm in